Okay, welcome back to our next video. In this video, we'll cover chapter number 7, the muscular system, movement for the journey. Brief introduction. The skeletal system will provide the framework for the body, but the muscular system is what allows for movement and locomotion. Now, in addition to the external movements that use skeletal muscles, the internal muscular movements, such as moving food from the mouth down to the stomach and through the intestines, all of that is done through different types of muscle. Same thing with moving body fluids in general, and then waste products, moving air, and so on. And different types of muscles allow for both external and internal movement. The learning objectives for this chapter: be able to differentiate between the three muscle types, discuss the functions of tendons, explain the difference between voluntary and involuntary muscles, and describe the various types of skeletal muscle movement. Also, be able to identify and explain the components of a muscle cell, be able to describe the chemical activities required for muscle movement, and describe the process of neuromuscular transmission. And lastly, contrast the activity of cardiac, smooth, and skeletal muscles, and discuss disorders of the muscular system. Alright, we'll start with a general overview of the muscular system. A muscle is a general term for any kind of contractile tissue, any kind of tissue that will or has the ability to contract or get shorter and then go back to its normal length. Now, the contractile property of muscle tissue allows it to become shorter and thicker in response to a nerve impulse, and then relax once that impulse is removed. This alternating contracting and relaxing is what causes movements, because that's all muscles can do. They can contract, get shorter, and then relax. That's all muscles can do. Now, muscle cells will be elongated, and they resemble fibers such as you find in a rope. And muscle tissue is constructed of bundles of these fibers, and each of these is approximately the diameter of a human hair. Okay, all muscles will fall into one of three different categories. Either will be skeletal, smooth, or cardiac. Alright, the first type, skeletal muscle. These are the voluntary muscles. These are the muscles that you voluntarily control. Now, you choose to open the door or close the door. You are choosing to pick up a drink or put it back down. You have conscious control over the muscle movement. And these muscles, their names will derive from where they attach in the skeletal system. And one big indicator of skeletal muscle, they are striated in appearance. That means they look like they are striped. They have an alternating light and dark patterns, and you'll see why that is here in a few minutes. Smooth muscles, these are involuntary. You have no conscious control over how smooth muscle works. So that's why it's called involuntary. And these are not striated in appearance. It's only one of the three that is not striated in appearance. And these will be found in some of the larger blood vessels, in some of the airways, inside these softer internal organs, spleen, liver, so on. Sometimes the smooth muscle is called the visceral muscle. Now, smooth muscle is what allows for the internal movement of food. So this facilitates movement of blood also by changing the diameter of blood vessels. Now, you have no conscious control over how the food that you eat moves its way through the digestive system. It's done through the activity of smooth muscle to push it along and move it forward. Same thing with blood vessels. Sometimes blood vessels will dilate to allow more blood flow in. Sometimes they will constrict to allow less blood flow. And that's done by rings of smooth muscle. Cardiac muscle, also involuntary. You have no control over how often your heart beats. And of course, cardiac muscle would be found only in the heart. That's why it's called cardiac. These are a very specialized muscle. These are also striated in appearance, like skeletal muscle. And the contraction of this muscle will cause the circulation of the blood throughout the body. Alright, here's a comparison of all three types. Skeletal muscle here. Now, voluntary. And only one of the three that is voluntary. So you go down smooth here. Involuntary, found in the hollow organs. They have what's called a fusiform shape. They kind of bulge out in the middle, then they kind of taper off on the ends. And the cardiac muscle, found only in the heart. These fibers tend to be branched, also involuntary, and also striated. Next, we'll move on to a pathology connection with myopathy. This is a general term for any muscle disease or disorder. Now, the causes of myopathy could be various types of injuries, could be genetics, could be medications, could be cell abnormalities, could be a nervous system disorder. Some symptoms of myopathy: weakness, cramping, stiffness or muscle spasms. And the treatment will obviously depend on the root cause of the myopathy. I'll get a little more detail on skeletal muscles. These will attach to bones, which allow you to move. Muscles have to attach to something, so muscles attach to bones. That's why they're called skeletal muscles. They are attached to the skeleton. See, tendons. These are the fibrous tissues that connect skeletal muscles to bones. And a good example of that would be the Achilles tendon. The Achilles tendon will attach the distal end of the calf muscle, the gastrocnemius, to the heel bone, the calcaneus. That's why it's called the Achilles tendon. And to contrast that with ligaments, ligaments attach bone to bone. So tendons go muscle to bone, ligaments go bone to bone. And some muscles attach directly to bone or soft tissue without involving any kind of tendon at all. Alright, skeletal muscle, it's called voluntary, like we mentioned before, because you have conscious control. In a normal situation, in a normal, healthy person, you have conscious control over how skeletal muscle works. Of course, for the main functions, responsible for movement, maintaining the posture of the body, generating heat, and giving body its overall shape and its form. This is why when you're cold, this is why you shiver, because your muscles are shaking to generate more heat. All right, here's an anterior view of some major muscles. There are over 640 muscles, so it'd be really difficult to find one image that lists every single one. But here are some very common muscles. And as you can tell, the names get more and more involved because they're all based on Greek and Latin names. There's the posterior view. And many muscles have a common name in addition to their more formal Latin name. All right, now we'll move on to another pathology connection. We'll talk about strains and tears. Now, a strain is caused by overstretching of a muscle or of a tendon. Now, injuries could range from a slight overstretch to a complete muscle tear or a complete rupture of a tendon. Injuries that are acute, resulting in trauma, or injuries that are chronic, resulting from overuse and disease. So a sudden injury, such as a sports injury, or a prolonged, long-term effect of a repetitive motion can also cause strains and tears. And the symptoms will vary greatly on severity. Some signs and symptoms, well, of course, depending on how severe the strain or tear is. Mild strain, there'll be no tear of muscle or tendon fibers. There'll be some mild pain and some slight stiffness. Moderate strain, there is some tearing of the muscle or tendon fibers. A little bit more intense pain. There'll be some bruising, and there'll be some weakness because there is tearing of the muscle or tearing of the tendon. Because you are altering the form of that muscle, the weakness will correspond to that. And then a severe strain is where you have a complete tear of the muscle or of the tendon. There'll be severe pain, swelling, very extensive bruising, and often a complete loss of movement. If the muscle isn't attached anymore, then it can't work anymore. Where you diagnose strains and tears, a physical exam, x-rays or MRIs, and medical history also. Various treatments for strains and tears. Of course, this will depend on how severe the strains are. In the first 72 hours, you have what's called PRICE therapy, P-R-I-C-E. You have protection, rest, ice, compression, elevation. Then after that initial 72-hour time frame, there's a gradual increase in activity or physical therapy, and then also the application of heat. And also you'll have pain relievers, such as acetaminophen, for example. Now for tears, these are going to be treated surgically at the time of diagnosis. And for strains, they're often fairly slow to heal because skeletal muscle and dense regular connective tissue has only a slight ability to repair itself, so it just takes time for that to heal. Alright, next we'll talk about tendinitis and tendinosis. The cause, this is a degenerative disease leading to the breakdown and eventually the scarring of tendons. And it appears to be caused by the failure of tendons to repair themselves after an injury. Some symptoms, pain, as you can imagine, tenderness, stiffness, and the symptoms really don't present themselves until the condition is pretty far advanced. Some risk factors for tendinitis, tendinosis. Some tendons are going to be more prone to going through this type of injury. such as rotator cuff, Achilles tendon, tibialis posterior tendon, patellar tendon, and tendons of the lateral elbow. Sports injuries, these are common locations for sports injuries. Rotator cuff, say for a quarterback, for American football, or a baseball pitcher, that's very common. Achilles tendon, anytime you have a very abrupt stop and changing direction, like a football player or a basketball player, that's a very common injury, to strain or completely tear the Achilles tendon. So this is a short list of some of the more common locations that'll be more prone to develop tendinitis or tendinosis. Some other risk factors: age, gender, skeletal anatomy, different types of occupational equipment that's used, and any kind of systemic disease like rheumatoid arthritis or diabetes mellitus. Some treatment types for tendinitis and tendinosis: price, protection, rest, ice, compression, and elevation. General rehab, physical therapy and rehab. Steroids in the very short term. You can't, or you don't want to overdo steroids. And then lasers also can be a treatment type. Ultrasound, such as shockwave therapy, for example. And then the very last resort for treatment type is obviously surgery. And even though this is the last step for treatment for tendinitis, tendinosis, it usually isn't that effective. And the prognosis is not as good for acute tendon injuries. All right, move on to another pathology connection, shin splints. This is a very common inflammatory injury of the lower leg extensor muscles and surrounding tissues related to running. So the best way you treat shin splints are rest, of course reducing the exercise intensity, ice, anti-inflammatory medications, and changing of proper fitting footwear. Here's an image of some common muscles found in the face. The frontalis in the front, that makes up your forehead. Temporalis on the temples, basically the side of your head. The masseter, the main muscle used in chewing your food, to masticate food, makes your jaw go up and down. Skeletal muscles of the trunk, both anteriorly and posteriorly. Deltoid here, shoulder would be trapezium here, or trapezius here. Pectoralis major here. Some skeletal muscles of the shoulder and arm and hand. Of course, the biceps brachii. Underneath that, the triceps here on the underside. The various extensors, flexors for the hands. Muscles of the hip and leg. Of course, the gluteus maximus, the buttocks that most people think of. The gastrocnemius, the calf. The hamstring group. The hamstring isn't just one muscle, it is a group of muscles. The quadriceps femoris group, because it is, the quads aren't just one muscle, they are a group of muscles. Here's a table of some major muscles and where their origin is, where they insert, and their actions. Of course, it would be difficult to list every single muscle in the body in a video like this, but here are some very common ones, like the biceps, like the triceps, the masseter, and so on. So muscle name, muscle location, where the origin is, where they insert. We'll talk about what those terms mean in a second. And of course the muscle action. All right, now we'll talk about another pathology connection, fibromyalgia syndrome. Myalgia, that suffix means pain or tenderness in the muscle. So when you have FMS, fibromyalgia syndrome, this is a very chronic pain syndrome. And it's something that is found more commonly in women. Some characteristics of fibromyalgia syndrome: you have pain for 3 months duration or longer. The pain doesn't go away, it's always there for a fairly long amount of time. You have bilateral tenderness, so that means there's tenderness on both sides of the body, not just one. Fatigue, sleep disorders, depression, anxiety, and exercise intolerance. All those are fairly common characteristics of fibromyalgia. The cause of fibromyalgia is currently unknown and does not seem to have any type of inflammation that is involved. It could be caused by hyperactive stress response by the body. It could be autoimmune. We just don't know. Okay. Also may be caused by sensory or neurological issues, leading to an increased sensitivity in pain. See, diagnosis. This is where you have, the way you diagnose fibromyalgia is having pain in 11 of the 18 designated tender points. These are located throughout the body. The way you treat fibromyalgia, there's no agreed upon definitive treatment for the syndrome. Symptoms can be managed: exercise, pain relievers, antidepressants, anti-epileptics, so on. But usually, managing your symptoms doesn't really do a whole lot of good, so it is fairly inadequate for most people. All right, next, move on to muscle contraction and relaxation. So the way your body moves is the result of muscles contracting or getting shorter of certain muscles. Now, the primary mover is the chief muscle that causes the movement, and there's a special term for that, and that muscle is called the agonist. And so as these muscles contract, it causes the bones to move. Now, the opposite of that would be the antagonist. That's the muscle that is doing the opposite motion of the agonist. And any muscle can be an agonist for one motion and an antagonist for another. It just depends on what particular type of motion that you're talking about. So, for example, when you flex your arm, like if you're flexing your muscles, the main mover in that would be your biceps. So that would be the agonist. So the opposite motion of that would be the antagonist, which would be the triceps. But if you do a different action, say if you extend your arm, well, the main mover in that is the triceps. So that would be the agonist in that situation. And then the opposite would be the antagonist, or the bicep. So it just depends on what particular type of motion that you are talking about for each muscle. Right, on that table, we saw the terms origin and insertion. And here's what those terms mean. The point of origin of a muscle is the end of the muscle that is attached to the bone that does not move. And then the point of insertion is the end of the muscle that attaches to a bone that does move. All right, is a common example with the arm. So in this image here, when you're flexing your arm, the main mover will be the biceps. So that would be the agonist. The opposite motion of that, the antagonist, would be the triceps. And for the flexing of arm here, where the muscle attaches to a bone that doesn't move, would be here, the origins. And the part that does attachment to the bone that does move, which would be here, that would be the insertion. Another term that you'll see with muscles, other than agonist and antagonist, is a synergistic muscle, or synergist. These are muscles that help the prime mover move. And like we mentioned before, the antagonist is the muscle that causes the opposite motion of the prime mover. So when one muscle contracts, another muscle relaxes. Muscles will always act in pair, like biceps and triceps. When one's contracting, the other one relaxes. There's always going to be an opposite connection between muscle pairs. Next, move on to the diaphragm. This will be the primary mover of breathing. The process of breathing is a very large dome-shaped muscle that separates your abdominal cavity from the thoracic cavity. It helps to change the air pressure inside your lungs to force air into the lungs to help you breathe. So this muscle is under both voluntary and also involuntary control. So when you take a deep breath in, for example, your diaphragm is pulling downward, flattening out, because its normal shape is like a bell curve or like an arch. So when you take a deep breath, it becomes flattened out, which means the volume of your thoracic cavity will increase. When that happens, air gets forced into your lungs to help you with the process of breathing. And there's the location of the diaphragm. It spans all the way this side of the ribcage to this side of the ribcage. And we'll talk more about the diaphragm's role with breathing in a future video. Next, move on to some movement terminology. The first one, rotation. Circular movement that occurs around an axis. You can rotate your head left and right. Abduction and adduction. These are terms we talked about in previous videos. Abduction with a B, moving away from the midline of the body. Then adduction is going toward the midline of the body. And the analogy I used in the other video, when someone is abducted, they are taken away from their home. So moving away from the midline for abduction. Extension, where you're increasing the angle between two bones of a connected joint. The opposite of this will be flexion, where you're going to be decreasing the angle between the bones. So when you're flexing your arm, the bones of your forearm are getting closer to the upper arm, to the humerus. So that's you're decreasing the angle between those sets of bones. When you extend your arm, you are increasing the angle between those two sets of bones. Here's a good example of that. And for here, he is bringing his arm up closer, so the angle between here and here is getting decreased, so that's flexion. When you straighten it out, like here, the angle between here and here is much higher. So that's about 180 degrees here. And this is probably about 80 to 90 degrees between that bone and these bones. Same thing with the leg. When you extend the leg like this, the angle between the femur, the thigh bone, and the bones in the lower leg is increased. That's about 180 degrees from here over to here. And here, when you're flexing the leg, the angle between this bone and these bones is decreased. This is about 90 degrees. Alright, now we'll move into the functional unit of muscle, and we'll focus mostly on skeletal muscle when we talk about these terms. Now, a typical muscle is surrounded by a layer of connective tissue called the epimysium. And this is continuous with the tendon. And anytime you see the ending mysium, that's always a reference to muscle. Inside the muscle, you'll have bundles of muscle fibers, individual muscle fibers. Those bundles are called fascicle. The wrapping around of every fascicle is called a perimysium. Peri means around, so it is literally around bundles of muscle fibers. And when we see the term muscle fiber, that's the same thing as saying a muscle cell. Those terms are interchangeable. And some muscle fibers can be as long as 30 centimeters or 12 inches in length. Now, inside those individual fascicles is another type of connective tissue that surrounds those individual muscle fibers, and that's called endomysium. So endo always means inside. So this is the connective tissue inside the fascicle. It's also where you'll find the myofibrils, the actual cylinders of the muscle fibers. Alright, inside the myofibrils, you'll find the actual contracting unit of muscle fibers called the sarcomeres. These are what will actually get shorter and then relax. These are what cause muscles to move, the actual contracting unit, the sarcomeres. So what you have is the myofibrils that are made up of protein threads that are arranged in these contractile units, end to end to end. And these myofibrils can either be thick or thin. The thick filaments are myosin, and the thin filaments are actin. So when we talked about the cardiac muscle and skeletal muscle being striped or striated in appearance, this is why they have that light and dark alternating pattern, because you have alternating patterns of thick filaments and thin filaments. So that's why it looks light, dark, because you have thick and thin filaments. Now, the actin and myosin are arranged in these repeating units, these sarcomeres, and they're separated from each other by these Z lines or the Z disc. And these Z discs are basically the bookends of each sarcomere. They form the boundaries of one sarcomere. Okay, every myofibril is made up of several sarcomeres. Actual contraction of muscle will cause these two types of myofilaments to slide toward one another and shorten the sarcomere. What you have happening is the thin filament, actin, will attach itself to the thick filament, myosin. That forms what's called a cross bridge, because you're forming a bridge between the two different types of filaments. Myosin heads will pivot toward one another, causing the edges of the sarcomere to be pulled closer together. That's what's actually contracting the muscle. So this happens millions of times, every single movement, all at once. First, we'll start with the organization of muscle itself. Of course, you have the bone here, then you have the tendon. Tendons attach muscle to the bone. The outermost lining with the epimysium, it wraps all the way around the entire muscle. These individual units are fascicles. What wraps around each individual fascicle will be the perimysium. So you have one fascicle that's pulled out going toward you here. That's one unit, one fascicle. The connective tissue inside each fascicle will be the endomysium. This is what will surround each myofibril, each muscle fiber. Looking at a sarcomere, Z line, that's one sarcomere here. For these two groups of images, you have a relaxed muscle here, and then a contracted muscle here, or a relaxed sarcomere and a contracted sarcomere. You have the thick filaments here and the thin filaments here. Then as they form the cross bridges and pivot toward each other, the Z lines are pulled closer to each other, so the muscles contract. That's how you get muscle movement. Alright, next we'll talk about another pathology connection. We'll talk about Duchenne muscular dystrophy. This is a genetic condition that is incurable. It's caused by a mistake in a protein called dystrophin and the gene that makes that protein. Now, dystrophin's function is to hold muscle fibers together during contraction. And without this protein working properly, muscle fibers will eventually break down and tear apart. Now, this condition will affect all types of muscles, not just skeletal, but can affect cardiac or smooth or skeletal. This genetic disorder is found on the X chromosome, so will be seen more often in boys. Some common symptoms of Duchenne MD, muscle weakness. As the disease gets more progressed, more muscle fibers will be broken down and will start to disappear. So the muscles become weaker and weaker over time. They'll become more scarred, and then they'll be filled with fatty deposits in the place where they are torn apart. And then you also have smooth muscle and cardiac abnormalities will develop as well. The course of the disease, it is a progressive disease, which means it does get worse and worse until the end point. It's usually diagnosed around the age of 4. By the time that child is age 10, they're almost always wheelchair bound. The average lifespan of someone with Duchenne MD is about 17 years. Of course, it is an approximation. Death is usually caused by respiratory failure or cardiac failure. The way to diagnose this condition, physical exam, there's a abnormality in the gait or the walking pattern of a toddler. You have a progressive myopathy and then a pseudo-hypertrophy in the calves. You can also diagnose this condition by doing genetic testing, doing biochemical tests for particular muscle enzymes, doing an EMG, electromyogram. This will measure the strength of a muscle contraction. So seeing where a muscle may be getting weaker and weaker could give you a pattern to diagnose this condition. There is no effective treatment for this condition, unfortunately. All you can really do is manage the symptoms. So we have assistive devices like a walker, like a wheelchair. Physical therapy is not a good tool to use here because the physical activity only makes the condition worse because the muscle fibers will be under more pressure or more strain, so they will break apart even sooner. There are some treatments that are still in the experimental stage at this point, and the main research now is being done to help repair the muscles that are currently there. All right, next move on to the roles of ATP and calcium. ATP, like we talked about before, the energy molecule, adenosine triphosphate, and then calcium. Both of these are needed in order for a muscle to contract and relax. So not only do you need energy to contract, but you need energy to relax that muscle. This actually is what's happening when someone dies and they have rigor mortis. After someone dies, the body will become relatively stiff. That's because there's no energy there to unbreak the bonds of muscle contraction. This will eventually happen over time, but that's the reason why you get the stiffness right after death, the rigor mortis, because there's no ATP there to relax the muscle. And what's actually happening is the ATP will break the cross bridges that's formed between the myosin and actin. When a muscle is relaxed, calcium is stored away from the actin and away from myosin in a very specialized organelle within muscles called the SR, the sarcoplasmic reticulum. And this is really just a modified version of the endoplasmic reticulum found in other cells. So when the muscle cell is stimulated, the calcium will be released from the SR, and this allows actin and myosin and ATP to interact, which will create the cross bridge and will lead to contraction. And when calcium returns back to the SR, the cross bridges are broken and then the muscle relaxes. So calcium is a very key component to muscle strength and muscle contraction. Now, when the nervous system tells the muscle to contract, a particular type of signal will cause the muscle fiber, or the membrane of the muscle fiber, to open sodium ion channels. This will allow sodium ions to flow into the muscle fiber, therefore exciting it. And this process we'll talk more in detail in a future video. When that muscle fiber becomes excited, this is what will cause the calcium to be released from the SR. So it is the calcium that causes the muscles to contract, and then the calcium after that point is pumped back to the SR to be used again later on. So if calcium is not here, muscles can't contract. If ATP is not there, muscles can't contract or relax. So all these things are based on all the components being there at the right time. If one part isn't there, the process stops. All right, next we'll talk about another pathology connection, Myasthenia gravis. This is an autoimmune disorder where your immune system attacks and destroys a large number of acetylcholine receptors at the neuromuscular junction. Now, acetylcholine is a major neurotransmitter used for muscle contraction, among other things. Some signs and symptoms. When motor neurons release acetylcholine, the muscle cell can't respond. You'll also get muscle weakness, and this will get worse with activity, but then it will get better when you rest. Because the more activity you have, the more acetylcholine that you'll need, and then when that happens, the muscles still don't respond. So when you rest, they get better, but then when you are trying to do some physical activity, the muscle weakness gets much, much worse. Now, the first muscles that are usually affected by myasthenia gravis are the eye muscles, but some patients will have some difficulty with chewing or swallowing or even talking. But usually the first muscles that are affected are the ones in the eyes. This is a rare disorder, more common in women that are under 40 and in men over 50. Difficult to diagnose this type of condition because it is rare. And what usually happens is people will have the condition for over a year before it is diagnosed. And a good way to check for this condition is to run blood tests for acetylcholine receptor antibodies, because that means your immune system is attacking the acetylcholine receptors. So that's really the best way to check for this condition. And also something that is unique for this condition is the fluctuating weakness. Muscles get stronger when you are resting, but then you get weaker when you're doing activity. That's usually a good indicator of MG also. Treatment, there is no definitive treatment for this condition. You can take corticosteroids, which is a class of steroids, immunosuppressants, because this is an autoimmune disorder, acetylcholine esterase inhibitors that will help block what's blocking the acetylcholine receptors, and also plasma exchange. By doing so, you are eliminating the antibodies that are attacking your acetylcholine receptors. All right, another pathology connection, tetanus, also known as lockjaw, is usually caused by a bacterial infection due to an untreated wound. And the bacteria that causes tetanus is Clostridium tetani, which is found commonly in soil. And what happens is this bacteria will release a toxin that keeps muscles constantly contracted, which is why you get the term lockjaw, because muscles are locked. Some common signs and symptoms: muscle spasms, usually initiated with very minimal stimuli. A loud noise or turning on a light, get a fairly aggressive response when you shouldn't really get that kind of response. Very rigid paralysis, stiffness, and pain are often good signs of tetanus. And the symptoms will appear usually 3 days to 3 weeks after the injury, and we usually will get worse and worse and worse, and if left untreated, can eventually paralyze the diaphragm, which means you will be unable to breathe. Common treatments for this condition, of course, cleaning of any kind of wound that you receive, an injection or some IV tetanus antitoxin treatments, being sedated, being put on a ventilator if it gets really progressive, and also pain management. Now, recovery of tetanus can take several weeks. Many patients after that point will still have long-term effects, long-term problems. The prevention is possible through vaccination, and the initial vaccine will be given in childhood, but then you'll need booster shots every 10 years or so as an adult to help maintain your immunity. All right, next we'll talk about muscular fuel. Muscles, like every other kind of tissue, needs fuel in order for it to work. So you need to get nutrients, you need to get oxygen to survive and also to function. Now, the body will store glycogen in the muscle. Glycogen is a stored form, an altered form of glucose or sugar. And it stays there until it's converted to a more usable energy source. So when needed, this glycogen gets converted back into glucose, which is your fuel for your cell. Now, muscles that have a high demand will store fat and use that for energy source also. Now, whenever you have an energy release, this causes heat to be made, which is why a prolonged, strenuous exercise can overheat your body, because you're producing more and more heat the more active you are, and the longer that you are active. And muscles that are under higher demand often have a richer blood supply because they need more oxygen for them to work. And these muscles will tend to have a darker color compared to other muscles. All right, now I'll move on to smooth muscle, also called the visceral muscle. These are found in the soft internal organs other than the heart, obviously. You find these in the blood vessels and the airways of the respiratory system. These have the ability to expand and contract, basically to help regulate blood pressure and to help regulate digestion. All right, vasodilation. Vaso is a reference to vessel, such as blood vessel. Dilation means you get larger in diameter, so you are enlarging the diameter of a blood vessel. This will lead to a decrease in blood pressure, and this happens because you have less resistance in the way. The opposite of that would be vasoconstriction. You are constricting or you are decreasing the diameter of a blood vessel, and this will increase blood pressure. During an asthma attack, the smooth muscles in the airways will constrict, vasoconstriction, making it more difficult to get air into and out of the lungs, which is why you get that wheezing sound when you have an asthma attack, because you're trying to move air in and out of a much smaller space. On a very particular type of smooth muscle called sphincters throughout the digestive system. And these are round donut-shaped muscles that act as doorways to let materials in or out of a certain area. And they do that by contracting or relaxing. When they're relaxed, you're able to move material forward. When they constrict or contract, they will block material from progressing forward. All right, smooth muscle is one of the two types of muscle we talked about that is involuntary. They also do not contract as rapidly as skeletal muscle. They're about 50 times as slow as skeletal muscle. They only receive a moderate blood supply, and because they get a lower amount of blood supply, it takes them longer to repair, heal itself when they are injured. Move on to cardiac muscle. Of course, which will form the walls of the heart. The contraction of this cardiac muscle will move blood throughout the chambers of the heart and eventually to tissues throughout the body. One of the two types of muscle that is involuntary. You have no control over how often or with what strength your heart beats. The fibers in cardiac muscle will be shorter, and they will be branched compared to the other two. The other two types of muscle are not branched, but cardiac muscle is. And these will have a much richer supply of blood than the other muscle types of the body. All right, the muscle fibers themselves are connected to each other by a structure called the intercalated disc, and their main function is to speed communication between different fibers of the heart. So when one fiber contracts, it will tell the other fiber next to it to contract also, which is what you would want when you're talking about something as important as your heart muscle. It has to contract all at once at the same time over and over and over again. So the more effectively these fibers are able to talk to each other, the more effective the overall heartbeat can be, and the more blood will be squeezed out in a more effective way. Now, the bad thing about a cardiac muscle, it does not regenerate. So once you have damage to this kind of tissue, it can lead to tissue death, which can cause scarring. And the scar tissue does not help muscles of the heart. It's just there in the way. So skeletal muscle can repair itself slowly. Smooth muscle can repair itself slowly, but cardiac muscle cannot. Once it's damaged and gone, it's gone, and it can't get any better. You see these zigzag lines, these intercalated discs. These are how the fibers are connected to one another, how they're able to speed communication. This is only found within the cardiac muscle. These are not found in smooth or skeletal muscle. All right, now we'll summarize some common muscular system disorders, strains or tears, etiology, acute injury, such as a sport injury, some signs of a strain. It will vary in severity. It could be bruising, it could be stiffness, it could be a total loss of function. Diagnostic tests, exam, radiological studies like X-ray or MRI, and patient history. And treatments will depend on how severe the injury is, but the price format is always good. Protection, rest, ice, compression, elevation, physical therapy, surgery if needed. Those are all common treatments for strains. Tendinitis or tendinosis. Etiology, chronic overuse or disease. The signs, pain, stiffness, weakness. The way to diagnose this condition, physical exam, patient history, MRI, so on. Again, price, the common treatment for something like this. Physical therapy, anti-inflammatory drugs, ultrasound, shin splints. Etiology, repetitive lower body exercise, such as running, is a good example of this. Could be due to improper fitting footwear or improper foot mechanics. Some signs, obviously pain in the tibia region of the lower leg. Way to diagnose this, physical exam, patient history. Treatments, ice packs, anti-inflammatory meds, decreasing how much exercise that you do to give it time to heal, maybe modifying the footwear, maybe more properly fitting, cramps, spasms. Etiology, a very sudden, very severe involuntary muscle contraction. It could be a result of prolonged physical activity. It could be due to high electrolyte loss or excessive fluid loss. Also, menstruation can cause cramps. Some diagnostic tests, patient history, physical exam, blood work to check levels of various electrolytes. Treatments, obviously rest from a specific task, rehydrating yourself, passive stretching, and replacing electrolytes that have been lost. Fibromyalgia syndrome, unknown etiology, could be neurological, but we just don't know for certain at this point. Some common signs, chronic pain, bilateral tenderness, fatigue, sleep disorders, anxiety, depression, exercise intolerance. Some diagnostic tests, having location of pain that's confined to 11 of the 18 tender points that are used for fibromyalgia. Treatments, really no effective treatment, but you can manage or attempt to manage the symptoms. Antidepressants, exercise, pain relievers, anti-epileptic medicines. Muscular dystrophy, or Duchenne's muscular dystrophy. Etiology this is a genetic defect of a very particular muscle protein, a protein that helps keep the muscle fibers together during contraction. Some common signs: muscle weakness in the early stages, and as you get later on, a progressive muscle weakness, including skeletal and cardiac and smooth muscle. Diagnostic test for MD, physical exam, genetic testing, biochemical testing, EMG, and also a muscle biopsy. There's no real treatment for this because this is a progressive genetic condition that is fatal. All you can really do is manage the symptoms, but there is some experimental treatments that are in development currently, but as of right now, you just have to manage the symptoms until the end point. Mitochondrial myopathy. The etiology is a defect in how ATP is produced in the mitochondria in cells. Common signs and symptoms: a progressive muscle weakness, often accompanied by diabetes, heart problems, hearing loss, certain nervous system disorders, biochemical abnormalities. Some diagnostic tests: genetic testing, biochemical testing, muscle biopsy, EMG. For treatments, there's no really agreed upon treatment for this condition. Some drugs can decrease the symptoms, but nothing has been shown to stop the progression of the condition. Myasthenia gravis, or Gravis. Etiology: it's an autoimmune disorder that attacks the neuromuscular junction. Common signs: this is a progressive, fluctuating muscle weakness. It gets better when you are at rest, but then when you're doing activity, muscles get much more weak much faster. Often it will affect the facial muscles first, like the eyes or the throat, swallowing and chewing, talking. Diagnostic tests for this condition: blood tests, EMG. Common treatments: steroids, plasma exchange, immunosuppressants, acetylcholine esterase inhibitors. Tetanus, or lockjaw. The etiology: bacterial infection due to the bacterium Clostridium tetani. The wound isn't cleaned out enough, so the bacteria is allowed to grow and fester. Signs and symptoms: a progressive muscle spasms, paralysis, stiffness, and pain, especially within the jaw itself. Some diagnostic tests: a physical exam, a lab test to rule out any other disorder that it could be, the history of the wound, the way you would treat this, cleaning out the wound, just some good wound hygiene, antibiotics, antitoxin for tetanus, sedation, ventilator support, and also pain management. Now we'll move on to the pharmacology corner. We'll talk about skeletal muscle drugs. And the first one we'll talk about are the NSAIDs, the NSAIDs, the non-steroidal anti-inflammatory drugs. These are drugs that will help relieve inflammation, but don't have the negative side effects that steroids do. Some common examples: ibuprofen and naproxen. Ibuprofen, also known as Advil, that's a trademark name for ibuprofen, and the trademark name for naproxen is Aleve. Some pain medications: aspirin, acetaminophen. Acetaminophen, also known as Tylenol. Some muscle relaxants, like the name kind of implies, will help muscles to rest in order to heal themselves. They're also used to help relieve musculoskeletal pain. These are also used to help relieve musculoskeletal pain or spasms. And some common examples: Flexeril and Parafon Forte. Some paralytic medications. These will clinically induce paralysis, such as during surgery. What happens here is these meds will cut off communications between the brain and the muscles. Muscles will only contract when they're told to contract by the nervous system. So if they aren't told to do anything, they won't do anything. So that's what happens with these drugs. And some examples of this: anectine and then Povilon. Now, something that has to be paid very close attention to using these paralytic medications is a very precise science. If you overdose on this kind of drug, this can actually stop your breathing or stop your heart. So this is not something that you just want to play around with when you're given paralytic medications. So even though the patient may be completely paralyzed, they can still feel pain and be conscious and aware. So if you are giving paralytic medications to a patient, it is really, really important to give other drugs also to sedate the patient. So you can't just rely on paralytics. Alright, that brings us to the end of this chapter on the muscular system, and we will continue our course with our next video, Chapter 8.